Hi, my name is Solène Lambert, and in this video I will show you why mentors take over in laparoscopic surgery, the limitations of telestration for remote instruction, and how these insights can inform future design of telementoring systems. Surgical telementoring is a form of mentoring where the expert mentor isn't on site with the operating surgeon, but remote. They have access to the surgical view, which is easy to transmit in laparoscopic surgery because the video is already being captured by a camera inserted inside the patient. Mentors can also point and draw on the surgical view using telestration tools. Telementoring with telestration tools has shown promising for remote instruction, but the main limitation of telementoring is the lack of physicality. In particular, mentors cannot take over the instrument to act on the body. While it would be useful to better understand this lack of physicality to design surgical telementoring systems, we still don't know how it limits mentors in instructing and understanding the surgery, namely how it limits in conveying and gathering information. So in this paper, we show that telestration and speech are limited for mentors to instruct and understand the surgery. And through showing the information mentors cannot convey and gather using telestration, we create clear design goals, challenge current evaluations of telementoring systems both in and outside surgery, and highlight new technological avenues. Before getting into the details of our finding, I'll provide a bit more context. So surgeons constantly need to update their skills as new techniques are developed and standards updated. To do so, they can learn outside the operating room using videos or simulators. They also learn inside the operating room through mentoring, where they operate and confront to the difficulty of surgery while being under the supervision of a mentor. In laparoscopic surgery, which is the surgery we focus on, the surgeons operate through small holes called Troccaz, where they insert the instruments and a camera. The camera is called the endoscope, and it records the surgical view, which is visible on the screen in front of the surgeons. Mentee and mentor are side by side. The mentee holds the instrument to operate, and the mentor holds the endoscope. And to guide the mentee, mentors typically rely on speech or manipulation of the endoscope. And when needed, they take over the mentee's instruments to further demonstrate a specific technique or to further understand the surgical scene. Once the mentor has taken over the instruments, the mentee does not perform the main operating gestures, but only assists the mentor in doing so. Although side-by-side mentoring has numerous benefits for learning, experts are often in different hospitals, cities, or countries, which makes it impractical for them to come regularly to the mentee's hospital. One way to bridge this gap is telementoring, where the mentor can guide the mentee from a distance using speech and telestration tools. For instance, the mentor can draw a line to indicate where to perform an incision. Previous research has shown the benefits of telestrations, for instance, to help train professional vision or reduce time spent on instructions. But there is still one major limitation of telementoring, which is the lack of physicality, as mentors cannot take over the instrument to act on the body. We showed in the previous work that mentors take over for different reasons. For instance, they take over to spare the mentee from risks and from workload, which includes advancing faster or unblocking situations. In these cases, takeover is inevitable. However, mentors also take over to explain or to gain additional information on the surgical scene. And in these cases, technology may support mentors in explaining and gathering information without physically being there to take over. However, to design such tools, it is first important to understand what information mentors convey and gather through takeovers, and the limitations of telestration to do so. So with this understanding, I will now present the research question we investigated and the method we used to do so. In the study, we investigated the informational needs mentors fulfill through taking over when side by side, and to what extent mentors can address these needs remotely through current telestration tools. To do so, we conducted 3 workshops with surgeons, each involving 2 participants, as well as 4 interviews. In the first phase, we explored events where mentors took over to instruct and understand the surgery and specified the information they conveyed and gathered during these events. In a second phase, for each identified event, we asked participants to judge whether telestration could have helped convey or gather this information. And lastly, in a third phase, we explored future tools that could overcome those limitations. Let's now discuss the results of our study. So first, we show that telestration and speech are limited for mentors to instruct, as they cannot convey all type of information. One example of that is when mentors need to convey instrument placement. Mentors sometimes ask mentees to adjust the orientation of their instruments, both on direction and role. And we found that speech and telestration could help communicate that type of information when there was a visible anatomical landmark, because then the mentor could easily point at it or refer to it, saying, grab here, or turn your instrument toward this structure. However, in many cases, there's no visible target to help indicate orientation. In particular, during dissection, the anatomical landmarks are not yet dissected and therefore not yet visible. In these cases, mentors cannot point directly at the undissected structure. They can only point at the surface of the tissue, which does not convey the direction of where to dissect. They can also refer to the undissected structure verbally, saying, for instance, put your instrument perpendicular to structure S. However, if the mentee's representation of the undissected structure isn't in line with the mentor's, then the mentee will not succeed in executing the instruction. So to overcome this limitation, participants proposed using videos to show examples of other surgeries. They also proposed using virtual instruments, which consist in having the mentor control and position stream images of instruments overlaid on the surgical view. Similarly, they proposed to use virtual anatomies, where a mentor would overlay a 3D models of tissues on the surgical view, and this would serve to indicate where the undissected structures are in order to guide instrument positioning. As soft tissues constantly change shape during dissection, one participant proposed that mentors deform the 3D models of anatomies to convey where they picture current tissues. Another information that mentors convey through taking over is force intensity. Here, telestration and speech couldn't help mentors convey this information. And so to overcome this limitation, and more specifically to convey the intensity of pulling, participants proposed using a physical tracting hook. The idea would be that the mentee and the mentor grab a hook with an instrument, the mentor would track the hook using a certain force, and then the mentee would feel that force on their side and resist it to gauge the force level. With the hook, the mentee would physically sense the resistance instead of relying on a visual or audio description. Besides conveying instrument placement and force intensity, we show that mentors take over to convey tissue displacement or movement, and that telestration and speech are also limited to convey this type of information. You can find more details in the paper. You can also find in the paper other technological avenues proposed by participants, such as dual pointers, 3D pointers, videos of mentors' hands, and anatomical charts. Aside from conveying informations, mentors also need to understand the surgery. And for this purpose too, telestration and speech are limited. For instance, mentors can be unsure about where tissues and surgical spaces are, which led them to take over. So they can dissect and displace organs until they find the tissue or space they were looking for. Telestration and speech was found to only partially help here. They could to some degree use telestration to instruct where to dissect or displace organs. However, mentors would face the same difficulty mentioned previously to convey information. To help overcome this challenge of identifying concealed tissues and spaces, a participant proposed using broader vision to give more context than just the endoscopic view. They mentioned a system where, in addition to the endoscope view, there are 2 additional cameras fixed on the abdominal wall to provide a contextual view. Another information that mentors can look for is tissue texture. This can help mentors, for instance, diagnose if a tissue is pathological or not. It can also help locate instruments covered with tissues and therefore determine the contour of this tissue. Lastly, stiffness of tissue can also inform mentors on gesture constraints. So gesture constraints impede mentee in executing instructions. And so mentors take over to experience and better understand those constraints. For instance, if a tissue is too stiff, it may not be possible to move it as far as the mentor would like. Another example of constraints come from troccars, which block the movement of instruments outside the body, making it impossible to attain certain targets. However, as those informations are not visual, but based on force feedback, no instruction, even using speech or telestration, could help mentor gather information on texture and gesture constraints. To inform mentors on tissue texture, and especially to communicate gesture constraints, participants proposed using sensors. And so as they understood that sensors inside the patient were not yet suitable for surgery, they proposed an alternative, which consists in using a sensor outside the patient, where the mentee could reproduce the force they apply during their gestures. So this relates to the proposition of the physical tracting hook mentioned earlier, but in this case, it would be that the mentee that would tract or push the hook, while the mentor resists the force to gauge it. You can also find in the paper other tools for mentors to gather information, including high-resolution videos, level to indicate horizontality of the camera, remote control of the camera, X-ray-like visions of the instruments relative to tissues, videos of Troccaz and instruments, predictive anatomical simulations, and names and colors to indicate force level. With this understanding of telestration's limitations for mentoring, let's now discuss the implication for future work in HCI. First, through showing the information mentors cannot convey and gather using solely telestration in speech, we create clear goals that designers can try to reach in order to mitigate the lack of physicality inherent to telementoring. Besides design goals, these results challenge current evaluations of telementoring systems, both for surgery and outside surgery. When examining the type of tasks in traditional evaluation, they often require transmitting information that our study participants judge possible to convey with speech and telestration, such as position of instruments when targets are visible. For instance, in Samsar 2019 paper, the tasks represent a dissection of an artery and a duct. Here, at the beginning of the task, the path of the ducts and artery are already quite clear. Unlike during surgery, where the whole challenge is to discover where the artery and duct are. In the task, mentor used color to refer to structure, saying the red structure is the artery. Unlike surgery, where even after dissection, the duct and artery have the same color. Without clear color and path of anatomical structures, it is more challenging to instruct, for instance, the correct instrument orientation necessary to perform an action. While simplification of tasks is inevitable for lab studies, we believe that focusing on reproducing the challenges we identified in this paper could help highlight telestration limitations and the benefits of other tools. For instance, tasks could focus on the discovery of invisible anatomical landmarks hidden in tissues, more than just the action of clipping, incising, or cutting on already visible structures. Lastly, our work highlights technological avenues promising to overcome telestration limitations. Some of the participants' propositions already exist in the telementoring literature. That's the case of virtual instruments. However, further investigation is needed to show if they can meet participant expectations of transmitting a diversity of information. Broader vision and videos are also studied in the literature, but not for telementoring. Broader vision has shown benefits to decrease blind spot of the operating surgeons, but was not studied as a resource for mentors, for remote mentors. Similarly, videos are often studied as an alternative to mentoring, but not as a resource for mentors to create instruction. Lastly, participants propose technological avenues that are not studied in the literature to our knowledge, such as deformable virtual anatomies or physical hook. Thank you for your interest, and please feel free to reach out to us if you have any questions or insights.